right, good afternoon. Thank you, everyone. I'm so appreciative of your making the time, and it's really fortifying to see all of you, not on Twitter, but actually right in front of me at this virtual table. So I really appreciate your making the time, and grateful to DeMarquan and my staff, who, when I said I wanted to make this a priority, immediately just got to work on it. And so I really appreciate your joining us for this roundtable on long COVID. Deeply grateful for your willingness to take time out of your day to engage in this conversation. As a handful, because I'm not the only one, but as a handful of the leaders advocating for congressional action on long COVID, your expertise is really going to prove invaluable to me in my advocacy and in this work. So I look forward to hearing candidly from our disability justice advocates, doctors, and researchers. But most importantly, I'm here to listen and to learn directly from those of you who are living with long COVID. Obviously, since the onset of this pandemic nearly 2 years ago, your stories have been overlooked. Your pain and your trauma have been neglected. And the burden this illness has put on you and your lives and the lives of your loved ones has really been shamefully ignored. And what's important to me is that you know that you are not invisible, that your suffering is not imaginary, and it's time that your lived experiences are recognized in the halls of power and in our COVID response. Long COVID is real. It is impacting people of all ages, from our children to our elders. It is afflicting our essential workers and those on the front lines responding to COVID-19, and entire families have been destabilized by its wrath. So with today's convening, which I hope to be the first of many, we can make progress towards a comprehensive, intersectional, and whole of government solution to long COVID, a crisis within a crisis. Congressional action is really long overdue. And that is why I wrote, and I thank so many of you for amplifying this across your platforms. It's why I wrote to the CDC this week, urging them to publicly report robust, disaggregated demographic data on the prevalence of long COVID. Congress needs this information to help us better understand the illness and to ensure that we are targeting resources to those who need them most. We can't manage what we don't know. I've always believed and seek to practice that the people closest to the pain should be the closest to the power driving and informing the policymaking. And so as you speak today, please feel encouraged and emboldened, and move with agency and being as precise and prescriptive as you can and as you see fit to lift what you are experiencing so that I can get to work on making things better. So without further ado, I'm ready to hear from all of you. And Karen, are you all right with starting us off?
Yes, I am. Thank you so much for having us and organizing this. It is so incredibly important to us to begin these conversations and start being consistent with these conversations. So thank you for hearing us. Thank you for understanding what we're going through. My name is Karen Bischoff. I am the founder of the COVID-19 Long Hauler Advocacy Project. I'm a single mom, Indigenous woman, and now former firefighter paramedic. I, along with 5 other coworkers, were infected in March 2020 by another coworker who had returned from a conference with positive cases. When schools closed, I worried that my son may have brought the virus over to my dad, a diabetic, when I dropped him to stay for weeks. I went to a first responders only testing site because that's all that existed at the time, and had to really fight to get a test because I no longer had a fever. My test was positive. After returning to work weeks later, on April 20th, 2020, I was terminated, and my department has refused to provide an answer to this day, even to my attorneys. I have had to fight my department lying to workers' compensation, which got my claim denied the first time, but I was thankfully able to prove that they lied. I've faced lots of medical gaslighting from numerous doctors, especially the workers' compensation doctors I was sent to. One told me I couldn't possibly have issues because I wasn't hospitalized, and all his other hospitalized patients were fine, so I should be too. The other told me that my issues were psychosomatic and that bringing a binder of my own medical records was a mental illness in and of itself, after literally being told to bring all my medical records. My claim was denied again because of this, and I haven't received benefits since December 2020. From January to May 2021, I was able to utilize pandemic unemployment until Governor DeSantis reinstated the work search requirement, making me ineligible. Since then, I've been dependent on a GoFundMe and $158 a month from temporary cash assistance, leaving me nearly $4,000 short per month. I was denied Social Security disability after applying, after being out of work for over a year with many new disabling conditions under my belt. I have since had to hire an attorney to help me with the appeals process, which I am currently in. To date, I've been diagnosed with POTS, ME/CFS, small fiber neuropathy, fibromyalgia, mast activation syndrome, IBS, chronic migraine, and numerous other conditions, none of which I had prior to my COVID-19 infection. I was a healthy 30-year-old firefighter paramedic playing soccer and working out, doing high-intensity interval training 5 times a week. Now I'm confined to my bed 85% of the time, still suffer from 80 different symptoms, and have seen nearly 40 doctors. Some days I want to give up and throw in the towel. Other days I'm on the front lines fighting, refusing to be swept under the rug. My son is currently the same age I was when my mom, an Indigenous woman in her early 50s, died from lung cancer after being gaslit and not getting the proper testing done. A big part of my drive is making sure history doesn't repeat itself. I never could have imagined how hard it was to navigate the system and manage your own care with complex chronic illness while being the sole caretaker for a child. I don't have the capacity to even wash my hair on a weekly basis, which resulted in my son having to cut out chunks last week. I don't have the ability to make a meal or do the laundry. I'm having to choose between paying my power or water bill. I'm requesting telehealth appointments to save gas so that I can commit myself to keeping one thing in my son's life as normal as possible, which is his opportunity to play for MLS soccer and something he's worked incredibly hard for. The inaction surrounding long COVID, the largest mass disabling event in American history, is inexcusable. The long COVID community has not been taken seriously or listened to, and clearly we have learned nothing from previous post-viral illnesses. Despite Dr. Anthony Fauci's irresponsible and dangerous comments a few days ago, mild and asymptomatic cases are relevant and do result in disability that significantly impacts society. Ignoring this is a disservice to the American people and science. Case counts matter, and long COVID is incredibly disruptive to society, and that is exactly the point of the open letter we sent to national leadership on January 10th. That has gone without response, but from 4 out of 3,500 it was sent to. It is a clear message that there is no help coming for us or our families, and we demand more from our nation's leaders.
Thank you, Karen. That was tough to hear and even tougher to live through every day. So thank you. Thank you. Anyone who would like to go next?
I believe I'm up next. So yes, thank you for organizing this and giving us the opportunity to share. My name is Lisa O'Brien, and I'm a COVID long hauler. I sit on the board as secretary of the COVID Long Hauler Advocacy Project, and I'm also the founder of the Utah COVID-19 Long Haulers Group, a local group that I started in June of 2020 that now has over 4,000 members dealing with long COVID to some degree. I got COVID on March 11th, 2020, the same week that the country began to shut down, and a few days after returning home from a trip to Hawaii. Prior to COVID, I was generally healthy with no known underlying conditions and lived a fairly active lifestyle. My first symptoms initially did not match the 3 that they were using to screen people that would provide me with access to a test. So when I finally got tested 2 weeks later, my results came back negative. This caused many issues getting doctors to believe me, and I was dismissed several times or told that I was probably just dealing with anxiety. Thousands of others have shared this same experience, and without diagnostic proof of COVID, many patients across the country are being disqualified from specialized long COVID clinics or kept from receiving proper medical treatment. Like a lot of COVID long haulers, the acute phase for me was mild, and I never required hospitalization, but my symptoms never went away entirely, and over time they began to change. I started having heart flutters in month 2, and it was around this time that I found the first long hauler support group, and that was when I knew that I'd had COVID because all my crazy symptoms aligned exactly with many members of the group. Getting through the first year was the worst. I cycled through over 50 different symptoms like erratic heart rates, internal vibrations, brain zaps, blood clots, cognitive issues, hair loss, and I could go on. Every day was different, and I could never predict what handful of symptoms would show up from hour to hour or day to day. This is how it is for many of us. During that first year, I was mostly bedbound, had to start using a shower chair to shower because my heart rates were so crazy every time I stood up and the heat intensified that. I used a wheelchair to get around at my doctor appointments and had to have my kids drive me to all those appointments because I didn't trust my body to behave the way it should. During the summer of 2020, I went to the ER 8 times in a 5-week time span and called the ambulance twice. Usually this was due to erratic heart rates that would sometimes drop into the 30s and hit 220 a couple times. There were lots of times that I didn't believe I was going to survive, and I had a few talks with my mom about what to do with my 2 kids and my belongings should I not make it through this. I was going to the doctor 2 to 3 times, different doctor appointments 2 to 3 times a week for the first 10 months, trying to find someone who would take me seriously or not brush off my symptoms for anxiety. This became expensive and I wasted so much time. It wasn't until month 11 when I was finally accepted into the Bateman Horn Center long COVID program. They are post-viral illness experts, and I finally received a diagnosis of POTS, mast cell activation syndrome, orthostatic intolerance, and told that my symptoms aligned with the hallmark symptoms of ME/CFS, commonly referred to as chronic fatigue syndrome. There is no cure for any of these syndromes. They are under-researched, under-recognized, and most doctors have not been formally trained on them. It's been almost 2 years for me, and while I'm not 100% recovered, I have seen a lot of improvement, but I am lucky because that's not the way it's been for many. Many in our groups are still dealing with debilitating symptoms 2 years out, and because of that, many have been unable to return to work, and those who have lost jobs have lost insurance along with it. Some are even being forced to make decisions between feeding their families or filling prescriptions. These are just a few of the many issues that long haulers are dealing with. The long COVID patients desperately need help now.
Thank you, Lisa. I have to say that what's been offered so far is a very consistent experience for women in healthcare.
Please press any key to remain in conference.
I'm sorry, and certainly women of color. And so I am struck by the fact that is there one long hauler who's here today who is a man? Because this is one of the reasons why we certainly need data, because I wonder if there is a disparate impact on women. And whether that is true or not, there's just so much we don't know when it comes to women, because there isn't an equality in research and so many other things. But we're always accused of being hysterical, or imagining things, or it's just stress, so in any event, thank you so much. Thank you, Lisa, for that. Okay, so Lisa's saying there are men. Okay, all right. Okay, who would like to speak next? I'm trying not to show my parochial bias to those from the Commonwealth. So, so who would like to go next?
So I'll go next.
Okay.
So good afternoon. I'm gonna have to use this because of my eyesight, so forgive me. Good afternoon. My name is Nisha McCrae. I'm a Roxbury resident of the 7th District. I'm also the executive director of a STEM nonprofit called Bajika, which I founded while an undergraduate at MIT. When we met in December 2019, Representative, we met when my BPS students visited you at the Capitol shortly after being honored by NASA Goddard for their work. Shortly thereafter, I woke up in March and felt an extreme migraine and tightness in my chest, which left me on the bathroom floor so short of breath that the room was spinning. When I reached out to my doctor, I was told, if you can talk, you're fine. In July, my partner and I, a fellow long hauler, thought a return to Florida for a few months with the hopes of a warm weather would help my recovery. Within days of my arrival and 30th birthday, I suffered a heart attack. 7 hours later at the local ER, I was sent home to just take a Tylenol. This was not my first time being gaslit by the medical community, and it certainly wouldn't be my last. 18 months later, there's this belief that mild COVID cases do not lead to severe consequences, or if you didn't have a positive test, you didn't have COVID. I am proof that is not true. A recent blood test reveals my initial PCR test in Chelsea was a false negative, likely due to timing. My mild COVID-19 infection should have granted me hospital admission. It didn't. The inability to smell or taste, the confusion, the short-term memory loss, down to the microclot responsible for my heart attack aren't my past COVID symptoms, but my present COVID symptoms. Nearly 2 years post-infection, almost nothing has improved in my symptoms and care, except my medical notes now state confirmed COVID-19 infection. It's been filled with moments of grief, like when I wake up to my 3-year-old niece saying, "Good morning, TT," and I can't remember her name or move my lips to ask her who she is because I'm physically paralyzed. To quote the late Bell Hooks, sustained grief is a particularly disturbing in a culture that offers a quick fix for any pain. The realization that there is no quick fix is why it took so long for us to arrive at the realization. There are long consequences to COVID. As 3 months became 6, then a year, and now 2 years, my medical treatment and loss of income thus far has cost me over $100,000, including $3,000 a month in seizure medication. That is inaccessible to the majority of Americans, let alone my community. I can't help but wonder what would have happened if we listened to our disability advocates when they warned us that COVID had the potential of becoming a mass disabling event. Perhaps we could have avoided our present fate and grief, but we're here now. Suffolk County has reported almost 200,000 confirmed COVID cases since January 2020. Yet we know nothing about the effects of long COVID in our community. We need to gather more information on the scale of this phenomenon, because last week I helped neighbors over the phone order rapid tests through the USPS because they didn't have internet access and had to inform them that their children who hadn't returned to their normal selves after COVID were likely long haulers. We need to launch a public education campaign that rivals the Got Milk ads to explain what long COVID is, the consequences of developing long COVID, and programs that can assist those suffering from long COVID, especially in communities of color. I would like to conclude my time by stating that lately, it seems that everyone is barking at the urgency of normal. But what is normal anymore? There is no longer a normal for the students you saw in December 2019 and for the majority of the 7th district. And I feel for many a community across the globe and this country. We need to focus less on a return to normal and more on not repeating our past mistakes to the detriment of those who've already shouldered the burden of this pandemic.
Thank you. Thank you. Eloquently stated. Lisa? We'll go Lisa, and then we'll go Hannah, and then Ann.
Sure, thank you. Thank you so much for having me, Congresswoman Pressley. Thank you so much for the much needed letter to CDC. And thank you for all of the work that you've done to support disabled people and other historically and currently neglected communities. My name is Lisa Mccorkle. I am a person with long COVID. I'm based in Oakland, California. I am a policy analyst with the California Department of Social Services in my day job, and I'm also the co-founder, along with Hannah Davis here, of the Patient-Led Research Collaborative, or PLRC. PLRC is a group of long COVID patients who did the first research on long COVID way back at the beginning in April 2020. Our research showed a lot of what has already been mentioned here, just a vast array of symptoms. We documented over 200 symptoms total, and we demonstrated the similarities between the symptoms of long COVID and other post-viral illnesses like myalgic encephalomyelitis, or ME/CFS, forms of dysautonomia, and mast cell activation syndrome. We showed that there is a huge impact on people's ability to work when they have long COVID. 2/3 of our respondents had to either reduce their hours or stop work completely. Shamir and I testified to Congress in April of last year, and unfortunately not much progress has been made since then that impacts the day-to-day lives of people with long COVID. but every day more people join our community. The vast majority of people with long COVID had an initially quote unquote mild case of COVID. So in the context of Omicron, we know that another giant wave of disabled people is coming, and we must act now because we are not ready. If people in our community are even able to access healthcare, they're often receiving harmful advice from providers, like being told to exercise and push forward due to a lack of medication or medical education in post-viral illnesses. Quality care is limited due to the vast underfunding and dismissal of post-viral illness before COVID. Folks are being denied accommodations at work that would enable them to continue working. They're being denied disability benefits of all types, private, short-term, SSI, SSDI, and are often not able to financially sustain themselves. And all of the barriers that people with long COVID are facing are exacerbated in BIPOC and low-income communities, reinforcing systemic inequities. Much of what we need has been called for decades: disability benefit reform, universal paid sick and family leave, Medicare for all. Some of what we need, we don't need to reinvent the wheel for. We need to mirror the federal response to the AIDS crisis and pass legislation like the Ryan White Care Act to ensure that people with long COVID, particularly the most impacted, receive adequate care and that medical providers are educated. We need better tracking of how many long COVID cases there are and who it's impacting, like you demanded. We need to know how many people are applying for disability because of long COVID and how many are being denied. We need to know how many people are no longer working because of long COVID. We need funding for post-viral researchers that have been doing this work for decades. We need research that meaningfully involves patients in their studies, research on treatments, and research on vaccine injuries that are causing long COVID-like symptoms. Ultimately, we need a coordinated and urgent federal response to this mass disabling event. And despite an estimated 21 million Americans experiencing long COVID, we have seen little action. I have many, many other thoughts, but that basically sums it up. Thank you again for creating this space, and I really hope you will be our champion and partner in this fight.
Thank you, Lisa. And I know that one, I just wanted to ask if it's possible that we can have all of your written, well, we're recording it, so that's okay. I got it. Okay. All right. So now I'm going to go over to Molly. I know Molly has to get to class, and we're so appreciative of your joining us today. So Molly.
Hi, thank you for having me. My name is Molly, and I'm a student at Northeastern University. I got my first symptoms back in March of 2020, with mainly being a fever, cough, and sore throat. Unfortunately, because I was 16 at the time and didn't have any previous conditions, I was not able to get a test because I was not considered at risk for COVID. Eventually, then 3 weeks later, after my mom started having symptoms, I was able to get a test, which then presented negative because I was out of my viral load. After that, about a month of original symptoms, I then started feeling better with a lingering cough, and then had a relapse in August of 2020. At that time, we had thought that I was reinfected with COVID with the similar symptoms, but for the first time, I felt like I couldn't breathe. Then in April of 2020, which was after I got the second dose of the vaccine and went back to school for the first time in over a year, these symptoms progressed, and I then felt very tired after coming home from one day of school a week, and often felt like I was short of breath. This then progressed when I came to school in September, moving to college with the increased level of workload, as well as having to walk a lot to and from campus. I'm now starting to see a doctor at Brigham and Women's in Boston at their COVID clinic, and saw a pulmonologist recently and got referrals to the cardiology department as well as immunology. I'm now seeking accommodations at school to help with my long COVID symptoms. The first part that I'm doing for this is to get housing accommodations for next year. Because my immune system has essentially disappeared, every time my roommate this semester has gotten sick, I then have as well, and have many times been left sick in bed for over a week. So now for next year, I'm trying to get the ability to have a single room, as well as being in a dorm that has an elevator, because walking up many flights of stairs has been extremely tiring for me. Additionally, for this semester, as well as next year, and as long as I need, I'm trying to get accommodations for my classes that will allow me to attend virtually if I'm feeling sick, or if I just want to be safe. And since, especially with COVID spreading, I'm trying not to catch it again. And also, I'm trying to get the ability to have extensions when I need. For me, COVID has been very unpredictable, and some weeks I feel fine, maybe being a little bit tired, and then other weeks I feel the need to sleep every single day and having a lot of trouble getting to classes on time and finishing my homework, as well as studying for tests. So having the ability to get these extensions that I need would help me with my recovery process, but also maintaining my grades and ensuring that my education stays the same. I've been in this process for about 3 weeks now, and I'm having to prove my illness, which makes sense, but it's also been hard, and I've noticed that I won't be guaranteed these accommodations, and I have to see what they can do, because these long haul COVID accommodations have not existed previously, so they're trying to see then what works with the school and for me. Thank you.
Thank you, Molly. Okay. Who would like to go next? Anne or Hannah, whichever.
I'll go. Good afternoon, everyone. Congresswoman Pressley, thank you so much for holding this roundtable on long COVID. It means the world to us, truly. I'm the vice president of the COVID-19 Long Hauler Advocacy Project, working with Karen and Lisa. And I'm a long hauler also from March 2020. And I'm Molly's mother. And I know Molly has to sign off any moment now. So I'm going to follow up on her story a little bit. When she became sick in early March 2020, as she began to feel better, I became sick and stayed sick for months. Our paths have sort of crossed throughout this illness. So as she was better, I was on oxygen round the clock at home for many weeks because as I've gotten better, though, albeit slowly, very slowly, and on a nonlinear path, experiencing more than 90 symptoms, including debilitating pain, post-exertional malaise, brain fog, migraines, fatigue, and POTS symptoms, Molly's health, as you've heard, has been deteriorating. I don't know what course her recovery will take. I mean, I am very hopeful for it, and that her new care will be beneficial, and the accommodations will help immensely, I am sure. And I don't know what long-lasting long COVID symptoms and impact she'll face down the road. As she said, it's been unpredictable, and things have come up when we've thought she's been better. So what's next? I don't know. As a mother, I find that upsetting. But it's upsetting on another level as well, because I personally have faced disease and chronic illness throughout my life. I had ovarian cancer in college, and I was diagnosed with MS about 13 years ago, in my late 30s. Over these 3 decades since I had cancer, I've become skilled at navigating the medical system. I've learned to fight for insurance in the days when pre-existing conditions were caused for denial of coverage. And I learned to search out skilled doctors who listened to me and treated me as an individual, because that's not always what happens, as we all know. But what's upsetting is that I never dreamed that we'd be repeating this with my daughter. But on the brighter side, I've had access to excellent care, in part because I learned to fight for it out of necessity. But I also recognize that I enjoy very real privilege as a white woman and as somebody who's educated and who has good health coverage. Those things make a world of difference in our country. When I was acutely ill with COVID, my healthcare providers weren't sure how to treat me, but they helped me find a COVID test. They never doubted I was sick, and they kept a close eye on me. They texted and called every day for months. When they weren't sure how to treat my long haul symptoms, we worked together to find people who could help. I've received an enormous amount of expensive care. I had 155 medical appointments in 2021 and 100 the year before. We've often been baffled by my symptoms, but I've always had access to care. I've been able to afford my copays. They've been expensive when you add those up, but I've afforded them. And I've never felt abandoned by the medical system to the degree that so many others have. In the United States today, that makes me lucky. Lucky. I was unable to work for a year and a half. I just went back to teaching. I'm an English professor last week, but again, I've been lucky. I have a union job and I work at a public university, and I had accumulated a year of paid sick leave. After that year was up, I had a semester of sabbatical in the fall, but every day of my sabbatical, I woke up worried that I wouldn't be well enough to teach in the spring. I just finished my second week of classes and I'm exhausted, but I'm doing it. And every day, nearly 2 years into this illness, I feel grateful for my good fortune. Is it not time to redefine what it means to be lucky in this country? Is it not time to recognize the basic human and medical needs of millions of long haulers who have not received attentive, affordable health care and a living wage throughout their illnesses? When I had cancer as a young woman, I was an anomaly. But today, millions of people, many of whom are young, have been plunged into a world of post-viral, often chronic illness, and nobody has offered them a lifeboat. We need to do better. And I'm so grateful, Congresswoman Pressley, for your leadership and commitment to helping that happen. Thank you.
Thank you, Ann. Thank you. I think it's either Hannah or Shamir who would like to go. Shamir?
Yes, I can go. Hey, hello, thank you. It's an honor to be with you, Congresswoman Pressley. And I just like to say that last week when I let Jamea Moore know from Baltimore, Maryland, as I am from, when I let her know that I would possibly be speaking to you, she assured me that I was in great hands. So it is an honor and a privilege to be speaking with you today and to join you along with my other long COVID colleagues. I just like to tell you that each week when I write in this journal, this is a affirmation journal, I see the handwritten note or the will that I wrote for my best friend to find so that she could execute it in the case of my death. Because from March 2020 until about October 2020, I was assured and I convinced myself and I just knew that I was going to die, whether it was going to be at the hands of COVID itself and all of the acute illness symptoms that I faced, or by my own hands. Because Congresswoman, I'm not sure if you know, but COVID does cause suicidal thoughts and suicidal ideations. We have lost many people already, far too many people at the hands of those who have committed suicide because they feel trapped in their own bodies. They don't feel like themselves and they don't feel like there's a way out. The reason why I started to become a long COVID advocate was because every day while I was sick, I would look at the news or listen to CNN because I couldn't quite see a lot of things because I had to be in the dark most of the time. I would hear and see sometimes long COVID or COVID being painted as a white woman's condition. And I knew in this Black woman's body that that wasn't true. And so What saddens me still today is that media and health reports still do not reflect, as you mentioned yourself, Congresswoman, accurate and current depictions of data that reflect Black and Latin populations of Americans with long COVID. It's been 2 years, and yet if I Google the number of Black and Latin patients who've had long COVID, I see nothing. There is no data that reflects that. So after I was sure that I wasn't going to die, I started to use the power of my good eye, because I lost vision for 5 months in this eye after doctors assured me that all I had was a dry eye. And so I had to use my good eye and my good hand to write emails to local council men and women in Baltimore City, because I needed somebody to hear me. If every day I woke up and I didn't die, I needed to make sure that somebody was listening to me. So I reached out to those Congress people. I reached out to state delegates. I reached out to doctors who had written articles about COVID, and I reached out on Twitter. And as I approach my 2-year COVIDversary, as we call it in our community, I must reveal another secret to you, Congresswoman, that since March of 2020, since I've been sick, I've also not been working. Now, I'm going to toot my own horn a little bit because I just have to. For 5 years, I was a middle school teacher in an urban Baltimore City community. I taught Black and brown students. I taught beautiful, intelligent, brazen and bold students. And on the very last day that I was in my classroom, because I haven't been in my classroom in nearly 2 years, the very last day I was in my classroom, I watched those same students stand on desks and chairs, not because they were being mischievous or misbehaving, but because they were reading and enacting and talking about and debating about Shakespeare's A Midsummer's Night Dream. They were enthralled with the cheating and the lying and the scandal of those characters. And we also were joined at that time by the Maryland State Department of Education. And one of the women that was in my classroom observing me as the students were leaving out to go to lunch, she tapped me on my shoulder and she said, I've observed many classes in Baltimore City. She said, I've never seen students so passionate about Shakespeare. And that's the very last time I was in my classroom. I miss being in my classroom. Teaching is what I love doing more than anything. And I feel so blessed to have done it for 5 years. But I must tell you, Congresswoman, that at 2:45, the thing I'd be doing probably on a Friday, if I were in the building, I'd probably be looking at that clock on the wall, counting down those 15 minutes to get those kids out of there for the weekend. But I miss doing that. I miss hearing their voices. I miss being called Miss Smith and Miss Smizzle. And I'm blessed, like Ann said, to have some of the privilege of having a long-term disability insurance that I paid into for 5 years. But I'm also grossly aware of the fact that low-income Black families and urban communities like Baltimore and small areas in Washington, D.C. have not had the same fortune, especially the families of the students I taught for over 5 years. Most of those students were living in nuclear homes with nuclear families, so they were connected to cousins, grandmas, best friends, uncles, and aunties. And I must say to you, and I know that this is probably true for all of us, had I not become an advocate, had I not spoken up for myself, I wonder where I would be, probably housed in my car with all of my stuff, because I am now, as I told Congresswoman Ashu from California in April, along with Lisa, I am now a poor Black disabled woman with long COVID. I've been in over 30 publications and media outlets since June of 2020. And I still see that in my communities, our health department just 2 weeks ago just acknowledged the prevalence of long COVID in Baltimore, featuring no patients of color and no patients without any privilege in webinars or in informational packages. I was called passionate and well-spoken, but like Lisa Mccorkle said, there's not been much done for all of that passion and well-spokenness to alleviate the problem that we face with long COVID. During my acute illness, I experienced racism and exclusionary practices and sexism at local hospitals by being treated. I was treated after white people, notably men, and by male doctors who used their gender and their assumed power to manipulate me into believing I wasn't sick or I wasn't aware enough of my own body and my own condition. And I don't know if you've ever experienced that, Congresswoman, but that is a devastating, traumatic experience. It is my hope that we can change a still sordid, conflicting narrative of what long COVID looks like in our country, because as we can see even today, it looks so many different ways. And it presents in so many different ways. Currently, what I'm dealing with is chickenpox marks on my entire skin. I'm talking about my legs, my thighs, my booty, my arms, and sometimes on my face, but makeup is covering it today. And as a body politic colleague who asked me to mention something else, we should not forget the elderly citizens of America, another marginalized group of people who are constantly being told that they should be lucky that they're alive. And like Ann Wallace just said, we need to redefine what lucky looks like in our country. And at 39, I too am being told that all the time. Well, girl, you should be lucky that you're not dead. But on some days, I'm gonna be real with you, I wish I was, because the pain and the trauma of the fatigue and the chickenpox and the skin issues and the inability to swallow and losing my vision for 5 months and not knowing until the very last minute that it was a dense cataract that causes me devastation all the time. Not being able to be in my classroom, not being able to remember what was said to me 5 minutes ago because I suffer from cognitive impairment and memory loss. I couldn't be a teacher if I wanted to right now because I wouldn't remember students' names, and I certainly wouldn't remember the most important things or characteristics about those students, which is what makes me a good teacher, is that I remembered those special things that made those students incredible. We need to fully admit, as I close, our failure to acknowledge what I now know is invisible illnesses like ME/CFS and long COVID, because those things, when we don't admit those, that failure, I'm sorry, let me just restart. We need to fully admit that our failure to acknowledge invisible illnesses like long COVID and ME/CFS can sometimes present as still being perplexing and destructive to our progress. People should not mistake my outspoken nature, sometimes my fresh haircut, not today though, and my makeup for wellness. These are just things I do and have always done to ascertain a sense of my own normalcy, especially now because I know I'm not normal anymore and I never will be again. After a life that's been devastated, traumatized by a virus I was told would go away after 2 weeks. Congresswoman, I just recently, about 6 months ago, was diagnosed with severe depression and PTSD. I cannot go past any school in this city without breaking down and crying. I went to Johns Hopkins 2 weeks ago to pick up some medicine, and I almost had a nervous breakdown and a panic attack because I hate going to Johns Hopkins. You know why? Because Johns Hopkins was the place that threatened to put me in a psychiatric ward because I came with notes of symptoms. They would not listen to me. They turned me away. I would love to see us reimagine and redefine care and caretaking in urban communities. Long COVID clinics and traditional medical centers are not always accessible by Black patients in Baltimore and some areas in Washington, D.C. We need to look at how we are treating those, as you mentioned, Congresswoman, those who need the most care and how we can help them and support them. And I thank you today.
Wow. I agree with Amanda. You are still teaching.
Mm-hmm. Thank you.
Yeah, thank you.
Mm-hmm.
Would anyone else like to share their experiences?
I can go. Thank you so much for having us here today. We really all appreciate it so much. My name is Hannah Davis. I'm an admin at the Body Politics Support Group and also a co-founder of the Patient-Led Research Collaborative, along with Lisa. I got sick in March 2020 in New York. I had just turned 32 years old. My first symptom was that I couldn't read a text message from a friend. And then an hour later, I took my temperature and realized I had a pretty low but small fever. I was unable to read for almost a year. I still have trouble reading. I had severe cognitive dysfunction, memory loss, tremors, dysautonomia, which is dysfunction of autonomic nerves, peripheral nerve damage, clotting markers. I still have extremely high cholesterol despite no risk factors. I'm still having difficulty driving, reading, still have a complete loss of executive functioning and short-term memory, and I still have not recovered. Before I got sick, I worked in machine learning and artificial intelligence with a focus on pedagogical tools for identifying bias in machine learning data sets. But since I've gotten sick, I've not been able to return to that kind of work. I'm considered a mild case by everyone's definition. At patient-led research, we've identified over 200 long COVID symptoms. It's a multisystemic illness. We focused on cognitive dysfunction and memory loss and found that those are among the highest most common symptoms, and they are as likely in 18 to 29-year-olds as those over 60. Long haulers have faced a lot of issues around test accessibility, in part because of what feels like a collective amnesia around the first wave. In the first wave, only 3% of cases were confirmed. To this day, only 1 in 4 cases are confirmed, but long COVID clinics and long COVID research still require a PCR or antibody positive test to participate. There's a lot of lack of information around antibody production. 1/3 of patients never make antibodies. 80% of those who lose antibodies are female. That is literally never talked about ever. There are additionally 6 research papers now that show that low or no antibody creation is actually a feature of long COVID and can be used to predict long COVID at the acute infection stage in both hospitalized and non-hospitalized patients. But there's no provider or researcher education around this. This lack of information prevents long haulers, especially those without access to healthcare, especially in the beginning, prevents them from getting care and participating in research. One of our biggest findings at PLRC was that the symptomatic differences between people who tested negative and positive, there were basically no symptomatic differences, but the biggest difference was that the positive group was able to get tested on day 6 on average. The negative group was able to get tested on day 43 on average. So when you think of having a negative test, that just means they didn't have access to a test. And of course, that disproportionately impacts BIPOC patients. There's a lot of misunderstandings about what long COVID is generally. Most long COVID cases happened after a mild or asymptomatic onset. The prevalence is higher in hospitalized patients, but because there are so many more mild patients, the vast majority of cases happened after a mild infection. Many did not have respiratory symptoms or low oxygen levels. There's not enough collaborating with viral onset experts, which is why I'm very happy to see Dr. Bateman here. There's a lot of reinventing the wheel. Like Shamir mentioned, there's been a huge focus on white women. This is the same exact thing happened with myalgic encephalomyelitis. They thought it was a white woman's disease for like 20 years until someone finally did a population study of 20,000 patients and found that there's no difference across race. But we're repeating kind of the same mistakes that we don't need to be repeating. Similarly, many providers, even some long COVID clinics, don't know that old-fashioned treatments like graded exercise therapy cause high rates of harm in patients with post-exertional malaise, which about 90% of long COVID patients experience. This actually causes patients to worsen and even become bedbound. There's a ton of research out there that show that microclots, brain damage, and poor cerebral blood flow and severe ongoing immune dysfunction are key components of long COVID, but that's not part of the discussion. It's really still focusing on just symptoms and whether long COVID is real or not. Current attempts to count long COVID are very few, and where they do exist, they don't ask about the right symptoms. A lot of people assume that it's a continuation of the acute symptoms, where we know now that it's actually a delayed onset of neurological and systemic and immunological symptoms. We need public communication that long COVID is a disabling illness that happens after mild cases to all ages, and that most of us are being diagnosed with serious conditions like dysautonomia and myalgic encephalomyelitis that have no cure and recovery rates of around 5%. very few experts and most doctors are not familiar with these illnesses at all. It was a very tiny field before COVID. They also don't know that ME can be degenerative over time to the point of being bedbound and tube fed, because basically any sensory input, including eating, including seeing light, takes energy away from you passively. Two of the biggest risk factors for getting into that state are exertion in the early stages of illness and childhood onset of ME. So we are not only putting people at risk for this future, this bedbound, tube-fed future, by not creating the early identification systems for long COVID and early implementation of pacing programs, but we're also putting hundreds of thousands of children at risk of this future by letting them be willingly infected. And in addition, I would say in addition to a public communication program, we also need accountability for those who are trying to discount or diminish the impact of LC, which includes large organizations, anti-lockdown organizations, insurance companies, but also a lot of disinformation by medical providers, including those who kind of haven't gotten up to date. Again, thank you so much for hosting this and for your time.
Thank you, Hannah. Thank you. Going to my friend here. Is Cap next?
Yeah, hi, how are you doing today?
Hi, good to see you. Congratulations on your nomination as well.
Oh, thank you. I appreciate that so much. Again, super glad to be able to attend this meeting. My name is Mia Ives Rubley. I am with the Center for American Progress with the Disability Justice Initiative. We have been spending a lot of time trying to get information on long COVID and figuring out how that's going to impact the larger scale work that we are doing on disability. So I'm so thankful to be allowed to listen to you all's stories, because I think that's extremely important as we continue to work on policy. Some of the things that I wanted to just point out right now, we're about to release a huge report or column on the increase of disability within the general population in the coming days, which is going to show over 1.2 million more disabled people in the sort of working age category, and talk about how that's going to impact a lot of our safety net programs throughout the United States. I think it's extremely important that we look at the rising rates of disability throughout the country and figure out how this is going to affect an already strained system that we have and that we've seen sort of collapse under this pandemic. We also know that over 400,000 more SSDI individuals died in 2020 in comparison to 2019. So we're seeing a lot of different, very, very concerning statistics that need to be fully examined to understand their impacts towards specific systems that we're working within. One of the things that I did want to also point out is the Housing Pulse survey just updated its most recent data that showed that 8.7 million people in late December to early January reported that they weren't working because either they had COVID symptoms or were caring for someone who had those symptoms. One of the problems that we are getting is that a lot of this data isn't inclusive of the differential between acute COVID symptoms and long COVID symptoms. And it's something that we need to pull from the data. I'm super glad that your office has released that, that letter, and I'm glad that we got to work with you all on that letter. But I think it's really important that we get disaggregated data and the differences between acute versus long-term. Again, a lot of the surveys right now, including the Housing Pulse survey, is not inclusive of that data. So we don't know in terms of what the implications are for long COVID. As most of you probably already know, most research surveys are showing that 10 to 30% of individuals who have gotten COVID are getting long COVID, meaning that they're lasting longer than 6 months, and many lasting for years. Unfortunately, a lot of our systems aren't ready to handle that. We have been pushing Congress and the White House on figuring out ways to look at the or Social Security Administration and figuring out how we can better sort of examine different cases to figure out ways to speed up processing of cases. Unfortunately, and Congresswoman Pressley, I don't know if you know this, but unfortunately, we have like pretty stunning statistics from the years of 2014 to 2019, which was before the pandemic, of 48,000 individuals who had applied for SSI or SSDI went into bankruptcy during the application process. And then we also saw that over 109,000 individuals had died during that processing. We know that that the case log at the Social Security Administration is extremely backlogged right now. Part of that is because most of the Social Security offices are working from home. They aren't able to do the in-person application processes, and we need to actually decide that we need better ways to allow individuals to apply for SSI and ways to speed up processing, because we are going to see a huge backlog as more and more individuals have long COVID. So I think that's extremely concerning, and I think it would behoove your office to also write a letter to Social Security to find out what are the ways that they're going to adapt to the current situation, because we can't have a system that we're continuing to think we're going to go back to normal, because I don't think there's going to be a new normal without us adjusting and making accommodations for that new normal. So thank you.
Thank you, Mia. Okay, Julie.
I appreciate the opportunity to be here today and speak with you. I really appreciate the stories that you all have shared today. Thank you so much for your courage in sharing everything with us. I'm a physician who specializes in physical medicine and rehabilitation, and I'm called a physiatrist. And the specialty of physical medicine and rehabilitation actually came about in the 1930s due to the polio epidemics. And so there's a long history of treating people with disabilities. There were two things that happened at once. Actually, World War II veterans were returning home, and we got better and better at saving lives, but not so great at rehabilitating people and having them function optimally. So the specialty of PM&R was really created out of that, and it's a major specialty. But it's still kind of a small specialty. There are 12,000 or 15,000 physiatrists in the United States. I'm here today representing the American Academy of Physical Medicine and Rehabilitation. They asked me to be here as someone who lives and works in Massachusetts to share a little bit about some of the challenges that we faced. The American Academy of Physical Medicine and Rehabilitation has been putting together some guidance statements around long COVID, or PASC is another term, and bringing together subject matter experts from across the country who've established post-COVID centers to really try and figure out, what's going on, describe it to the best that we can right now, given the information that we have. The issue of having deaggregated data is super important. I mean, we just don't have great data on this. It's such an important thing. I'm so happy that you are advocating for that. We really need that. I do think that it's really clear that long COVID is affecting more women than men. And it's really clear that it's affecting more people who are, socially, historically, have been marginalized communities. Women with intersectional identities and their families have just been really crushed by the epidemic, including healthcare workers who have very high rates of COVID and very high rates of long COVID as well. So I think that that's really important. From a PM&R or from a rehab point of view, some of the things that are top of mind for us include, number one, maintaining access for telehealth. And that includes telephone medicine for patients who are not able to use the computer well. So prior to COVID, it wasn't reimbursed in general, or it was challenging to get reimbursement. We didn't use a lot of telemedicine. And my colleagues and I did some of the first studies on patient satisfaction with telemedicine in rehabilitation specifically, including physical therapy, occupational therapy, and speech therapy. And I think that was really important in terms of trying to develop a little bit of an evidence base for continuing to pay for these services and have access to these services. Another thing that I think is really important is that around the country, inpatient safety net hospitals for inpatient rehabilitation safety net hospitals are closing, and that's disproportionately affecting communities that have, BIPOC communities that have tremendous rehabilitation needs, and especially now. I think that, one of the things that I'm very concerned about as well, I do a lot of research on both patient care disparities as well as workforce disparities. I'm very concerned about the workforce. And the high educational debt, the lack of generational wealth, high educational debt, and coming into just, the pandemic, we have an exodus of women, including BIPOC women, leaving the healthcare workforce and leaving frontline jobs, as we heard earlier, with paramedics and firefighters and so on. So I think that stabilizing the workforce and maintaining services for patients is really important. One thing that the AAPM&R has been really great about doing is including in the guidance statements that they're writing information about health disparities. We've been very intentional. We're writing guidance statements because clinical practice guidelines is sort of the next level, and we don't think we have enough evidence for that. But just keeping in mind that clinical practice guidelines literally move money, to somewhere or away from somewhere. And so if you include information about healthcare disparities, you're literally moving money towards health disparities. And that's super, super important. So we've had a team, including me, an African-American physician in Talia Fleming, and a Hispanic Latina physician named Monica Verduzco Gutierrez, who've been working on this. We work as a team, and we work together on making sure that the content in these guidance statements from a health disparities point of view is accurate and inclusive. So thank you very much for having the opportunity to be here today.
Thank you for your participation and for your leadership. And now we'll hear from Lucinda.
Thank you so much for the chance to come, and thank you all of you who've been here to speak. It's kind of an overwhelming situation. So thank you for listening, Congresswoman Pressley, and giving us the chance. It's hard to know where to start. I'm a trained general internal medicine specialist, and after practicing my first 10 years of practice and seeing so many people with multi-system illness, chronic fatigue syndrome and fibromyalgia, decided to specialize in this area in 2000. I was working as in private practice, so limited, right, in my ability, but there was one thing I really couldn't do, and that is have a cash-only practice. I had to see patients who represented all people, but even then it was only people with insurance. right? And people who could get in to see a physician. After 15 years of working really hard to understand this clinically and to play a role in advocacy and education and start to join in research, I just was searching for a way. Imagine, if you can, working with people just like this as my entire practice. So my entire practice is people with myalgic encephalomyelitis and chronic post-viral syndromes. And it gets overwhelming, right? And for years, for decades, these same patients with ME/CFS and other post-viral syndromes have not been able to access healthcare, have been treated disparagingly, have had trouble maintaining employment due to their illness, and have had a major struggle with getting financial support and disability. So that's my life. And I decided to form a nonprofit clinic and research center in 2015. So we melded a small nonprofit and my clinic so that we could continue to find ways to have resources to help our patients and to get the message out. But it's been challenging. And one of the hardest things for me is not being able to see more people. But in the nonprofit model now, our mission is not to see all the patients, but to use a Center of Excellence model to see as many patients as we can, to engage them in research, and then to take that information out and disseminate that information, both to patients and to medical providers. So that's what we do at Bateman Horne Center. And in February of 2021, as we're all doing this journey in the pandemic, and it became more apparent that there were many patients with long COVID and a post-viral syndrome so similar to what we've been studying. We hired 2 advanced practice clinicians who'd had more than 15 years of experience specifically to see long COVID patients. And in doing so, we created a very structured intake with standardized questionnaires, orthostatic testing, 2-3 hour workups so that we could really understand long COVID, specifically to see how long COVID compares to the illnesses we've been studying, ME/CFS and all the comorbid conditions. And it's really, we only saw people who had not been hospitalized. So our entire practice of long COVID is people who were never on oxygen, were never in the hospital, and a lot of them were never had positive tests. And we have learned so much, but one of the things I've learned is I was completely stunned by the disability and the severity of illness in long COVID. The degree of cognitive impairment, we do cognitive testing as well as orthostatic testing, and the amount of cognitive impairment and the amount of physical impairment is just unbelievable. And I just want to pass on that message. We don't have the ability to be a major long COVID clinic. We're a clinic that tries to, again, do research and learn from the patients that we see and disseminate that information, but it still takes funding. And, it's hard to get funding in this to do whatever is needed in medicine. So it's super important that we get federal funding for support of patients, support of long COVID research, and support maybe even for the clinical management of long COVID patients, because it's much more time consuming. It needs to be, because it's a multi-system illness. So the doctor needs to assess all these different aspects of illness and manage it as a single multi-system illness. I would say that I agree with you totally. The biggest immediate need is efforts to understand the extent of long COVID in the United States. How many patients are they? Where are they? What's happening with them? Because knowledge of that will lead to the next steps into physician education. We definitely need to educate physicians and all clinicians who are caring for patients. There's no excuse for clinicians on the front lines to not understand about long COVID and to be able to offer supportive, compassionate, and intelligent medical care to any patient who hasn't recovered from COVID, even if we don't have all the information about what to do. There is no excuse for turning people away and for blaming it on anything other than what we know it is based on the science. So I'm not going to say anything about long COVID because you heard it all here. And I did not hear one thing here that was inconsistent with my practice. Plus, there's a lot more. So I'll just leave that message with you, and I can be a resource in any way possible. And we do have a website with lots and lots of information on it about these illnesses. So I would invite people to visit the BatemanHornCenter.org website. Thank you for the chance to come talk to you.
Thank you, Lucinda. Amanda, would you like to offer something here? Thank you for being here. You've been one of my most vocal, teachers. I've learned so much from you online, and thank you, for your support and for being here today. We'd love to hear from you.
Well, thank you for listening. When all of this started, I didn't think anybody would hear us, let alone listen. And I was really touched by what Anne said earlier, and I'm sure you feel this as well. I'm also a medical anomaly. I grew up in the healthcare system. My dad is a hospital administrator. He was an EMT and a pharmacy tech as well. I was a certified nurse assistant, but in a small town hospital, everybody does everything. So coding, billing, transcription, and I've worked in large facilities, name it. I've seen it, I've done it. But because I'm an anomaly, I grew up with asthma. It was pretty severe until I moved to Kansas City in 2012. Yeah, I had my son, my beautiful son, my perfect son in 2012. 5 months postpartum, all of my hair fell out. I was ungodly tired. I was more concerned with what's going on, why can I not get out of bed? But I had something visible. And I think that's the only reason every doctor in two healthcare systems took me seriously. They listened. We couldn't really find anything specific. So when COVID hit and I didn't get better after a month and then 2 months, I just thought, it's just me. I never thought it would be like this. And then a friend reached out and said, my sister is still sick. And then another friend, and I thought, oh my God. They said, you should start a Facebook group, do one of your groups, because I solve everything in life with the Facebook group and Google Docs. And I was like, yeah, I'll do that. But a lot of us hit this wall about a month or two out, and I hit it hard. It was everything I could do to stay awake. And when I finally got through that, June 23rd, 2020, I had this sharp knotting pain in my chest that radiated down my arm. I was 43 years old at the time. And I thought, this is not how this ends. This is not how this ends. I wasn't in a good place going into this. I had a very ugly divorce, very nasty custody battle. I was homeless for 4 years. I got into my apartment May 24th, 2018. And then when COVID hit, I was working in the gig economy. When you work in the gig economy, if you're not working 80 hours a week, you're not eating. But I knew, oh my God, if I get anything else on top of this, I don't know what that's gonna do. I could not believe I made it through that first round. I would go to sleep every night thinking, please let me wake up. Please let me wake up. But my downstairs neighbor was elderly and had COPD, and I thought, no, I'm not giving this to him. I'm also very lucky. I know this, people are, you're not, why do you say you're lucky? No, I am very lucky. I am so lucky. I have an amazing network of friends. My family, but my friends, they're my army. They came together. They would come over and take my trash out. They took my mail up. They would bring groceries. My apartment complex, however, was not exactly behind any of this. It didn't really matter in Missouri about the eviction moratorium. I wasn't evicted. They just said, we're not renewing your lease. So I lost my home on July 31st, 2020. And I was lucky. A friend happened to move to Kansas City from Iowa, and she said, come stay in our basement. So I spent most of the past year building what I thought would just be a Facebook group of support. We're gonna find 50 people and be miserable together and never have answers, just again. And that's not what happened. And because I didn't have insurance until the end of November. In Missouri, it used to be you had to file everything in paper. I'm not going out there. The library is not even open. I didn't have a printer. Well, how am I doing this? But they changed it. So at the end of November, I was able to get on Medicaid. I was able to file online, and I got Medicaid. And I went through the first 2 rounds of COVID guessing. I didn't have any tests. I had a chest x-ray through a community clinic the first time that showed bilateral ground glass opacities. That's the only proof I had. And I got sick on March 6th, 2020. I actually got it from my son, who was sick with it on February 29th, 2020. But I was lucky to get it again in October when I tested positive. I was working as a contact tracer for the health department at the time. And by then, I knew what to do. I'm staying right here. I am wearing a mask. I'm staying down here in the basement. I'm not going anywhere near anyone for several weeks. The health department was wonderful, but as hard as I tried, I could not. And the funding ended March 15th, 2021 anyhow. We have not done contact tracing in Kansas City for quite some time. But I had all of this knowledge, and I've had a really rich life. I sang opera for 10 years. I was an archaeologist before this. I can barely walk up a hill right now without feeling like I'm gonna die. Walking up a hill with all of this equipment, there's no way I can do that. But I'm okay with that. I am okay. I've done all the things I wanted to do in life. I got to be an archaeologist. I got to be a pirate in Fiji. That's a great story. I've sung with Itzhak Perlman. I've sung at Carnegie. But right now, this is my focus, and I don't want this to have to be my focus. It should not be. There are so many. I just want to take a step back and go back to teaching cool kids cool things. But we have so many issues to address. I am not the only gig worker affected. We've created this culture, not just in the United States, but really in other places too. If you don't work, you starve, you lose your home. And when you get sick, you need, especially post-COVID, you need that time to recover. Not this, I don't know what we're down to now, 5 minutes of recovery for the CDC. I'm not down with that. But I think one of the things that we're forgetting in all of this is that this is a global effort. It's not just us. It's not just one precinct. It's not one state, not one city, not one country. Globally, we need to be on the same page. And that requires having a cultural incorporation to this as well. And not just I'm from this culture in this country, also a microcultural difference. I wasn't always a city person. I'm from I grew up in Joplin, Missouri. We were kind of in the news this summer with Delta. It was devastating. There's a very big difference between rural and urban. What works in Kansas City will not work in Joplin. And we need to take these things into account, because if we're not listening to people, what their beliefs are on what is this, how do we treat this, what will work for you, we're not going to get very far. But we have to do this. We have to make a global concerted effort. We need this diversity. We need different opinions. We need different approaches. Without that, if we just all had the same idea and the same approach, we're not going to get very far. It's when we generate, even I love brainstorming, and I teach all of my kiddos with my enrichment classes brainstorming. Even if it's a terrible idea, just write everything down, because even a terrible idea can lead to a fantastic solution. And right now, every piece of this puzzle matters. It really does. So we need to enable not just our federal government. Oh my God, we need systemic change. We need to enable our local and our state governments. We need to enable the very nimble grassroots organizations who can go in and target the assistance we need. We need to be alive to participate in this research. I would love to go in and have some of these tests, and I don't know what's wrong. I don't want to be falling downstairs anymore. I have not driven since May. I would very much like to get into a home. There is nothing out here for us. And we can, we'll call 211. Okay, what happens when you call 211? Have you tried calling 211? And we need to celebrate the strengths of each person involved, each clinic involved, each culture involved. All of this to say that as dark as this is, all the horrors we've seen, and I know that there will be more horrors to come, I'm very optimistic, because we have this amazing chance to bring about systemic change on a level we've never seen. I mean, here we are. We were just tweeting in the woods talking about, hey, alopecia queens. And now let's change the world. This is, I'm excited. I'm terrified of a lot of things, but I'm excited too. So as long as I have this bad boy right here in my hand, we can do this. Thank you so much for your time.
Of course. Thank you, Amanda. And now I think we're going to hear from Peter.
Hello, everybody. Thanks for having me on to the community and to Congresswoman Pressley. I appreciate the opportunity to just give a few remarks. I won't take very long given the time that we have, but my name is Peter Chenhang. I'm a faculty member at the University of California, San Francisco. I'm an infectious disease doctor and a medical educator, which I think both of those spheres, I think I can give some comments or recommendations. I'm originally from the Caribbean, from Trinidad, before I came to the US for training. So communities of color are part of my fabric. I'm from a small village, so it means a lot to me. And I think not really understanding the impact of long COVID in all our communities is I think one of the biggest questions that we have, because interventions could be very, very different in each community. So I'll speak for each of my different areas. So as an infectious disease doctor, even before COVID, I've taken care of patients in clinic with other infections who have post-infectious chronic symptoms, and it's been very difficult to treat them. And I think a lot of the themes that people talked about today, I think resonated with even those early experiences, like people not believing them, people stigmatizing them. And I think my next hat, which is education, comes a lot to it. And these have been echoed by many people, because you're not going to get sensitivity in healthcare or by healthcare providers unless people know about this, and not only the current healthcare professionals, but the professionals of tomorrow. So as an educator, I think it's not only important, to think about, having healthcare professionals know about this and legitimize it and not turn people away, and have bear witness to their symptoms and when they come into the system, but also to educate the leaders and the professionals of tomorrow. So I think we have to think about integrating a lot of this knowledge into the curriculum for students in nursing and dentistry and medicine and pharmacy, physical therapy for tomorrow. So what do I see? I'm not going to repeat a lot about long COVID, because all of you have been so eloquent, and I've been listening to all of your stories with awe and humility for the entire last hour and a little bit. But I think we can learn a lot of lessons from other infections as well, and particularly the way that people have organized around trying to understand, trying to treat, and then trying to educate around illnesses. So I think HIV is a really good example. One way that patients and providers and researchers have coalesced around HIV is some of the things that have already been discussed, like having these multidisciplinary clinics, like centers of excellence, like you've all been to, but I think they've not been scaled up around the country. And then it gets to the idea of communities that may not even know that they have a place to go to. I think all of you are very aware, but I'm worried about the people who are not aware and who are suffering in silence. So that gets to access. So what the ACTG did, which is the AIDS Clinical Trials Group, is that starting in 1987, they just formed these centers funded by the government to bring the experience of multiple centers across, because you can't just study, long COVID from one center here or one center there, but you have to really bring a lot of patients together in a network, and that requires funding and organization. And I think that could be a model in which we can try to understand a lot about what's going on. I think that One of my other areas of interest is really thinking about trying to identify people with long COVID earlier so we could possibly intervene. And I think one of the most interesting papers that I've read recently, which many of you have probably seen, was reported recently from Cell, where they looked at 4 main features that predict people who have long COVID, and they include the amount of virus in your blood early on, activation of Epstein-Barr virus, which is another infection that people have, the creation of autoantibodies, so not antibodies towards COVID, but your antibodies that can attack your own body. And then the 4th thing is patients with diabetes. And the reason why I think this is really important is because we can try to develop therapies around these areas, but also try to intervene, prevent people from getting long COVID, because again, as people had mentioned, there's going to be a huge group of folks in the future with these symptoms, and we can try to hopefully have awareness and intervene now so that a lot more people don't suffer in the future. So I think these are some of the things that I think Congresswoman Pressley, you can advocate for in Congress. We need an organized effort, not just a random group of people asking for money from one center or another, but actually an organized way of educating, developing therapeutics, and destigmatizing all of long COVID. So that's some of what I have to say. So thanks for your attention.
Well, the perfect, summary and sort of a capstone, to our discussion here, particularly that final point, destigmatizing. Well, I'm very grateful for everyone's transparency and candor, and as I've said about so many other challenges in our society, I look forward to the day where you don't have to weaponize your trauma in order to be seen and heard and to have your needs met. So I'm very grateful that you would share so much with me. And I also thank you for being instructive and prescriptive about where we should go from here. That will enable me to be a more full-throated and effective advocate and champion on your behalf. It's so much, and yet I know we've barely peeled one layer. It's, so it is a lot to process and to understand. But I'm ready for the challenge and committed to all of you because you matter.